Well, before I introduce Dr. Rich, just a perspective from the over 50 set, I think using the camera as a tool, I think the trick to advanced laparoscopy is just to make a video, because if you do that, there's no bleeding. The sutures place themselves effortlessly, and the ureter appears magically with perfect, well-choreographed peristalsis. So I think you just press the record button and the case proceeds perfectly. I have a soft spot in my heart for pioneers. I trained with Dr. Barber, who invented the concept of a pelvic exoneration. Advanced cervical cancer can recur centrally, involve the bladder, involve the sigmoid, and he just invented the concept of taking those organs out rather bravely in the 1940s and 50s, and he cured half the patients. I was in an office with Dr. Decker, Wayne Decker, whose father, Albert Decker, went to the morgue and just invented coldoscopy, where you placed a scope with the patient in a knee chest position, and you placed the scope in through the cul-de-sac, and you were able to visualize the tubes and ovaries rather well. Dr. Sciarra, we all use UpToDate. The residents go to the internet to get the latest. He invented the concept of knowledge as a dynamic, and textbooks as an open dynamic issue, and he had updates placed each month. And this was when I was a kid. And there's no better introduction of Harry Rich to realize that he is on one of the slides that Dr. Sciarra placed. Dr. Sciarra's slides go back to the 1800s with the invention of hysterectomy, and they proceed into the 1900s, and lo and behold, 1989, Dr. Harry Rich up and invented advanced laparoscopy and the first laparoscopic-assisted vaginal hysterectomy. I think that's the best way to place Harry Rich in perspective, so I invite you to talk.
Thank you very much. I'm going to change my order of talk a little bit because Antonio is going to come back and show a lot of hysterectomy indications and whatnot later, and maybe some cases. But what I'd like to ask right now, are there any general surgeons in the audience? And I'm sorry, of course. And are there any urologists in the audience? Because that's going to make me really change my talk, because I wanted to show some of the complications in those special fields. But I just recently heard that the American Urological Society is trying to make most urologists doing robotic prostatectomy to get them a way to grant them bowel privileges, because evidently the injuries to the rectum are more than we ever thought. And I think I'd like to see gynecologists move in that direction, but I'd like to see that for the last 25 years. But still, we call the general surgeon to help us in some of those situations. So we'll show you some of that, some of the early days of general surgery done by laparoscopy in the next 30 minutes. And for the residents, these are some handouts that were printed up on a chapter I wrote in 1988. It goes through the basic techniques of laparoscopic surgery through the beginnings. For me, my beginning was a laparoscopic oophorectomy in 1976. So I felt very comfortable as a vaginal surgeon doing most things without abdominal incision from a very early time. And the idea of doing the whole operation laparoscopically came on a day when two other cases that canceled, so I did the whole operation laparoscopically instead of doing the upper part laparoscopically, which would be the oophorectomy part, and then going down below to do a vag hyst. So soon after that, we started doing the whole operation through the laparoscope. So by the end of 1988, we were doing the whole operation, in many cases, laparoscopically, not abdominally. Okay, what I'm going to do is just show you a couple of important ideas I have about hysterectomy, and then we're going right to endometriosis. So that way, Antonio will know what he has to correct me on when he gets up here later. Anyway, financial disclosures. I did have some interest in Apple Medical, but it was bought by Cooper. I have no idea what they're doing with those nice little trocars that we developed in the late 80s. But we'll see. Anyway, general surgery, it's been a revolution in laparoscopy, an abrupt and violent change, while in gynecology, as we all know, it's been a slow evolution, and it's slowly evolving, and the robot may have something to do with hurrying our cause, but I believe that as people get better and better with the robot, they'll throw it away and go back to doing the whole operation with the laparoscope, with laparoscopic basic instruments, which we know we can do. Hysterectomy, well, we know that you can do it abdominally, vaginally, or now laparoscopically. If we review the literature quite concisely, it says that vaginal hysterectomy is best. It should be performed when possible. Where vaginal hysterectomy is not possible, laparoscopic hysterectomy may avoid an abdominal incision. What type of hysterectomies are being done in the United States now? Well, most are being done still by laparotomy. And of the laparotomies, it surprises me that 6.4% are supracervical. With laparoscopic, we see a smaller number, but 9% of all hysterectomies today are supracervical. And this statistic disturbed me, and I'll tell you why in a minute. Anyway, you could check out how vaginal hysterectomy has frustrated many of us practitioners with its acceptance with Dr. Julian's editorial in the OBGYN Journal 2008. Supracervical hysterectomy is done in 9% in the United States, but in Denmark it's done in 30% of cases. So I asked myself, what is a hysterectomy? I mean, I thought the cervix was part of the uterus, but many of you don't think that anymore. So is a hysterectomy simply taking out the uterus or more? Well, does taking out the uterus include prophylactic or indicated vaginal support repair? That's a very important area that I've been interested in for a long time. So every meeting I go to, though, there's a big session, sometimes a whole day on correction of prolapse, especially now that mesh, which I had trouble accepting in the first place and never did, now that people are looking at that a little bit more carefully. I suspect that industrial boards sit there and they say, what can we do after the uterus is out? Well, one thing you can do is don't take out the whole uterus, leave the cervix, and you could have another operation. And then after that, you could have another operation for the prolapse that will occur in many cases with a hysterectomy with a supracervical approach, as I'll show in a minute. Why are we doing a total abdominal hysterectomy? Why, the Richardson technique was mentioned by Dr. Sciarra. 1929 it was published, and it was written in response to problems created by supracervical hysterectomy. The major changes in technique introduced were extrafascial removal of the entire uterus with anchoring of the anterior and posterior vaginal cuff at the corners to the uterosacral ligaments. Well, what is a supracervical hysterectomy? To me, it means take out the top, leave the bottom where the pathology is, especially when we deal with endometriosis, as I'll get to in a few minutes. Charge lots of money, but please don't call it a hysterectomy if the cervix is considered part of the uterus. Removal of the uterine fundus with preservation of the cervix. The data up to this point is very questionable. And for every article we read about speculations regarding loss of orgasmic ability, other articles pretty well indicate that this certainly is not true. And we're dealing back to an article from Finland by Kilku, who dealt with severe hypermenorrhea patients at that time. And most of the people in Scandinavia have rejected that concept. When we talk about pelvic support, in reality, pelvic support is vastly improved over baseline if the uterosacral ligament cardinal complex is attached to the upper vagina and endopelvic fascia is brought together. Quickly, do we have data on all of this? Well, I'd like to just show you some data, so I'll skip through a couple slides and get to the most important article on this whole debate that I know about, and that is this article. If any of you haven't read it, you should. Pelvic organ prolapse surgery following hysterectomy for benign indications. So you say, how could we get and see what's really going on? I mean, this came out of Sweden, and in Sweden they have a registry, and in that registry they have a list of every single person who had a hysterectomy. So, and that goes from 1973 to the present, so they could compare 162,000 women with hysterectomy to 470,000 without hysterectomy, and look at the modes of hysterectomy in relation to future surgery for prolapse problems from the cervix or the cuff. And what they found is the overall risk of subsequent prolapse surgery was increased by 50% after abdominal hysterectomy with an incision. It was doubled after subtotal hysterectomy, and it was quadrupled after vaginal hysterectomy. That doesn't bear well, I don't think, for subtotal or especially for vaginal. So if we analyze the data, though, the last two areas there are on laparoscopic type procedures, and we'll see that they're going to go along around the same rate as subtotal hysterectomy. And why is that? I mean, the bottom line is that people who do laparoscopic hysterectomy in most places today still don't pay enough attention to cuff prolapse and cuff support. And by that I mean that with some of our industrial devices that have come out, especially this little device that sews, the sewing machine device from, I think it's Covidian, I mean, no support could possibly be obtained using such a fine little device. So the vaginal cuff just hangs there with no support. In many of these cases in the future, we will find will prolapse. So the data's there. Supracervical, if you do it and you talk to people like Tom Lyons, who was an advocate, he spends a little time on the uterosacrals, bringing them into the cuff. I think it's important if you do this operation, don't doom your patient to another procedure down the line for cuff prolapse. Now, so my conclusion, there's some bad laparoscopic surgery been done out there, and hopefully we should do better in the future for our patients. Vaginal hysterectomy, I think, again, you have to grab those uterosacral ligaments and bring them together. My solution's always been, the way I was trained, was to bring the uterosacrals and the vaginal epithelium together across the midline with a high McCall type coldoplasty that you could do vaginally, but you could do better laparoscopically because you could see the ureters, you could see where they are, you could really take the uterosacral almost up to the sacral promontory without considering vaginal mesh. Now I'm going to stop right here and go to endometriosis. But we'll be discussing hysterectomy a little later on, and that will go here. This is lots of slides, lots of video. But Tamir, keep track of the time. I don't want to tell me when I have about 5 minutes left, okay? So I'll be sure to get off at that stage. Now, I've been assigned laparoscopic treatment. Okay, cul-de-sac and bowel endometriosis. Well, when I started treating endometriosis, the state of the art was similar to in the 16th century. The art of medicine consists of amusing the patient while nature cures the disease. Well, unfortunately, with endometriosis, that doesn't occur. If they have endometriosis, and I question whether many of the people diagnosed with endometriosis today truly have endometriosis. Remember, retrograde menstruation, if you look in, it causes brown little spots sometimes in the peritoneal cavity. That's not endometriosis. Endometriosis is a diagnosis made, in my feelings anyway, it's a diagnosis that can be made in the office, as I put in this slide, with a good exam, but really the sine qua non is endometriosis glands and stroma in the pathology report, or under the microscope, shall we say. Okay, let's do a quick slide on diagnosis. A rectovaginal exam should be done routinely in patients with pelvic pain and our past history of endometriosis, despite patient discomfort. Now, I see there's many residents here. I ask you, do you do rectal exams on most of your patients when you see your patients? Does anybody? I see some head shakes this way. But somebody who's dealing with pelvic pain or endometriosis type patients or people who are susceptible to it, you have to do a rectal exam, because if you do a rectovaginal exam, you could elevate the cervix with the index finger and feel the whole posterior part of the pelvis, and especially the uterosacral ligaments. And at least if you're going to do surgery on a patient, you could map out where the patient hurts and where at least a biopsy should be taken. So I like to stress that. Do an exam, do a good exam, elevate the cervix, feel the uterosacral ligaments as far as you can up. Endometriosis treatment choice. Well, medical treatment never works. In my 30 years of practicing, I don't know of a single case where it worked. And I know of not a single case where it eliminated endometriosis. So if there's endometriosis present, you put people on suppression, and you come back 6 months later, it'll still be there. So your choices are pelvic reconstruction by laparoscopy or laparotomy. Hysterectomy has always been a poor choice for endometriosis, because many of the surgeons, when they do these operations, they leave the endometriosis behind. They do intrafascial dissection, leaving endometriosis on the vagina and especially the rectum. Again, the supracervical, I say supracervical disgrace because, well, you'll see in a second when I quote some of the figures that I saw at Columbia. At Columbia, I said, well, is the treatment of endometriosis by laparotomy a myth? Well, when I was at Columbia, and this is what we looked up in 1998 and 1999, we found 424 patients with pelvic pain, discharge diagnosis of endometriosis. Laparotomy was done in 108 of these patients. At Columbia, over a 20-month period of time, 76 patients who had laparotomy had abdominal hysterectomies, and 20 of these had supracervical hysterectomy with bilateral salpingo oophorectomy. Supracervical hysterectomy was typically done for women with extensive cul-de-sac disease that could not be adequately resected at laparotomy despite the presence of a colon and rectal surgeon for 8 of these patients. Well, I hope that's not the situation today. But that's the way it was back then, a little over 10 years ago. So no laparotomies were done to excise endometriosis at Columbia that we found. Laparoscopy, I think mainly when I was there, was only excisional cases that would find their way to the pathology lab. So I stress that it's been a long time coming, this concept of excising endometriosis. But we've been doing it for so many years, and we've been presenting it to, I sense, deaf ears. This is a paper that I had published in 1991 after submitting it for 4 years to various different journals who just said this is something that gynecologists shouldn't do. Notice I said laparoscopic treatment of cul-de-sac obliteration. This was 100 cases, secondary to retrocervical deep fibrotic endometriosis. Deep fibrotic endometriosis, not deep infiltrating endometriosis. Somebody else, I think, at an academic center came out with the concept of infiltrating endometriosis. Well, I don't believe it. I don't believe endometriosis is infiltrating. I think it's fibrotic disease surrounding endometriosis glands and stroma. So I think deep fibrotic endometriosis is a lot better term than DIE, die. It's not die, it's not a malignancy. It can involve any pelvic organ, including bowel, rectum, bladder. Radical surgery, well, I think patients with pain, I think it is mandatory. Unfortunately, it does necessitate advanced training, such as for malignancy-type surgery. And that's happening now. With a robot, your oncologists are doing more and more laparoscopically, and they're gravitating toward endometriosis as they run out of cancer cases. These operations have been around for a long time. Thomas Cullen wrote about endometriosis before 1900. 1914, he said the removal of extensive adenomyoma of the rectovaginal septum is infinitely more difficult than a Wertheim hysterectomy for cancer of the cervix. So endometriosis, again, you take chunks of tissue, look at them under the microscope, you see glands, stroma, and fibromuscular tissue. Take another specimen inside the septum, you should see the same thing. Glands, stroma, fibromuscular tissue. Okay, now we'll start with some sort of relatively easy situations like this. You can see not much endometriosis here, a couple little spots. Whenever you see the white, if somebody says there's endometriosis and there's no white, I don't believe it. It's not endometriosis. Endometriosis has to cause some damage to the patient. That damage is a chronic inflammatory response. So you get white, fibrotic tissue surrounding. So here we are. Here's endometriosis. We look, okay, what do you do? Now, my technique is called cold scissors. I use cold scissors with microbipolar backup. I think Antonio's going more to bipolar now, it looked like, in that little picture, shaking your head. But I like cold scissors because I could feel the disease. It's hard. If the tissue's soft when you cut, it's not endometriosis usually. You want to stick at the junction of normal with deep fibrosis. And deep fibrosis, you could usually lift up and cut across it. And because endometriosis blood supply is a microvascular blood supply, you get some oozing, but in most cases it'll stop pretty much over the following 5 minutes. So you can cut across it. If you do this with normal tissue, you get a lot more bleeding. But if it's chronic inflamed tissue, engorged tissue with developing microvasculature, you can cut across it. It's okay. And it helps you to see your landmarks better. you know if you cut a uterosacral ligament during hysterectomy surgery, it bleeds. I mean, but if it's filled with an endometriosis nodule, the bleeding is minimal and it will stop on its own. So anyway, we're going to take out this chunk of the cul-de-sac. As you can see, here's the chunk of tissue. This is what was there. Now let's see what's left over. Okay, the tissue over the vagina has been removed. But here I come over to the right uterosacral ligament, and notice again, you can cut on the fibrosis and come across, in this case, from right to left. And then the end of it is to get the rectal disease, which it's almost always, if you have rectovaginal endometriosis, which septal area is most common because the rectum is tented up there, there's going to be some disease on the rectum. So you have to decide how you're going to handle that. So here we come over to the rectum. First part of the operation is to separate rectum from vagina down to the loose areolar tissue of the rectovaginal septum. We can then, because it's deep fibrotic disease, we could lift it up, we could feel it. This is another area why I asked that question about the urologist with the prostate, because you're working close to the rectum. We're working very close to the rectum. And we can, in many cases, take these lesions off without getting into the rectum. We'll come back and get the rest of that lesion here in a second. So we can, in this case, it's like a transverse bar of a lesion. I can come very close, go right across, and stop it. Okay, let's continue. 3 techniques we have for the rectum. Shaving, which you just saw. We could put a probe underneath inside the rectum and shave across it. We could excise it in a disc excision. And more you see people doing the segmental resection today. Here's a nodule. First part of the operation is separate rectum from posterior vagina down to loose areolar tissue of the rectovaginal septum. Here's the loose areolar tissue of the septum. This is what the rectum looks like after you separate. There's a lot of endometriosis in that. So what I do is I use a circular stapler. This is a technique I developed in the late, early 90s. In the year 1995, I did 35 of these bowel resections. But the technique is basically to take the lesion, invert it into the jaws of the stapler, as you can see, and fire it. So here, we insert the stapler. We can put the whole lesion into the jaws of the stapler, bring the stapler together anteriorly. Usually my assistant will hold the handle far down so I don't get posterior wall of rectum, and I fire it, and then we check it underwater with blue dye. This so-called flat tire test doesn't really work. It won't show you very thinned out areas. You'll think there's no leaks, but if you have blue dye, as I hope to show you in a few minutes, you'll see the thinned out areas of the rectum. Anyway, in this case, we then take the stapler, separate it, take the specimen out. You see it takes a nice specimen, and here we look under the microscope, and one can see in the muscle wall the endometriosis gland, stroma, and fibromuscular tissue, and also in this case coming through the mucosa. So, again, I said medical treatment never works. If you look at cure rates with Lupron, in almost all studies they're near 0, regardless of disease stage. Surgery, most reports are over 50%, they say cure. I don't think so. I didn't have 50% cure. What do we mean by cure rate? The only way you find a cure rate is by doing another laparoscopy at some interval in the future. That's what I would feel anyways. So this was presented in 1988, And basically, we present 100 cases, 67% persistent endometriosis after extensive excision. Remember, this is 1983 to 1988. Our cure rate, I would think, then was 33%. With more modern techniques, I'm sure today it would be, I'd get up to where my colleagues around the 50% range, maybe more. But the other thing is the concept of interval laparoscopies. You could look at that too. I think the endometriosis excisor in most cases should maybe consider a second procedure, rarely more than 2. You should be able to get the job done then. And does it come back? I don't believe so. In my experience, if you remove the disease, it's gone. It's gone. Anyway, let's go to the technique. Basically, I use sharp scissors. I operated with my eye for the first few years of video, and I switched over to just using the video in the early 90s. In the early days, we used a curette in the uterus, sponge behind the cervix, and a probe in the rectum. I like the Valchev manipulator because I can move the uterus up and down and around and see the cul-de-sac well. And these are some early cases. You could see a lot of disease down there. We would free the rectum and clear these areas. Again, cases like this. I just show you this to say, we've been doing this a long time. It's not something just new at this point. Let's get to more cases. The surgery, as you see with all that disease, first off, you usually have to take down adhesions, usually from other surgeries, mainly other laparotomy surgeries. So we take down the disease, we separate the rectosigmoid, find the ureters. If they're connected, most of the time they're not. Most of the time, if you take a uterosacral ligament and pull it toward the midline, the ureter sort of goes away there. But if not, you have to dissect it out in rare cases. So the cul-de-sac dissection part of it, it just really means separating the rectum from the posterior vagina. And once all that's done, we excise the disease. Let's see. I think I'm running out of time anyway. So, okay, these are some of the earlier cases too. This is one of the first times that we started using the robot. And I said that some of these cases came to 2 laparoscopies. Okay, this is one such case. And look at that. The rectum is fused to the back of the uterus, and I'm using a carbon dioxide laser. I wanted to show you how we did it with cutting current electrosurgery, but that slide misfired. But anyway, we were able to use the carbon dioxide laser. Hard to see much with these cameras in those days. But this lady had extensive disease, and we excised a lot of cul-de-sac disease. And when we looked at her again, this was 2 years later, you could see the cul-de-sac is still free, but she has a rectal nodule. And this was a case back in '89. I believe this is the first rectal resection. And this was back in '89. I had to resect that, and that did the trick. And Tamir's given me the eye here, so I think I better say thank you at this point. I'm going to have Antonio is going to talk about hysterectomy a little bit more. And we'll talk more about endometriosis for the next 2 days. Thank you very much for your attention.